Winson, Manuel alluded to this, the immunotherapy combinations, this whole concept of turning a cold tumor into a hot tumor. Can you tell us a little bit about that?
Well, in my prior life in Vancouver, before moving to Calgary, I actually treated melanoma. So I've seen, when it works very, very well. And I think we're all still very hopeful that maybe different combinations might do its trick. So I think, I think we're kind of crossing our fingers and hoping for the best, because I think, when it works extremely, extremely well.
Yeah. Thomas, what's your take on that?
Well, I think there is some potential, but we need to find really the way to combine immunotherapy, immuno-oncology with the respective other drugs that actually make it worthwhile. Maybe there are bifunctional antibodies that will give us a better answer by really forcing the immune system into the tumor. I think simple checkpoint inhibition is probably not going to work. We need additional components.
Yeah, and even chemo combinations probably, do you think we'll probably need more than that with immunotherapy?
Most likely, and even adding on top like MEK inhibition might not really be sufficient as well.
Yes.
So we will learn that, and we need to do the trials, and we need to really do smart trials to get the answers quickly, not to have too many patients involved which do not benefit, but then again, we shouldn't try everything we have just as a Rubik's Cube approach, and we need, of course, to rely on basic science that really gives us at least some clues where to go.
And I think you bring up such an important point is clinical trials have become so complicated, and I get pushback from people that are trying to put patients on the study saying, why do I have to get this fresh biopsy for this study? Why do I have to do this? And I think my answer back to them is this is what clinical trials are now, because we're trying to learn.
Yeah.
So even if we have a negative study, we're going to learn something from those biomarkers and realize that there may be some patients that will benefit more than others, and we need to know who those patients are. And so trying to reinforce that even though clinical trials are becoming more complicated, there's method to our madness. So I'm bringing it all in today, no stops. So what I'm going to do is go across, and because this is on film, right, the crystal ball, right, and so when we come back in 5 years, who's right? And now it's captured for posterity. Everybody give their pick of if you were a betting person going to Vegas, what do you think will give us the most benefit for pancreas cancer in the next 5 years? And I'm going to start with Thomas.
Well, I would say in the neoadjuvant setting, we know who benefits, and we will treat those patients in the neoadjuvant setting, and they will have a 5-year overall survival rate above 50-60%.
Shoot high. Wow, you're tough. Hey, it's
Crystal
your dream.
ball.
You're allowed to. Tony?
So I don't bet. But I do come from a family that also has lawyers, so you got to be careful about what you say to the camera, because it can come back and haunt you one day. But in all frankness, I think the biggest bet is that we're ultimately going to be able to break this disease down into multiple subgroups. And I think it's very clear that the BRCA/BRCA-NS is one. The MSI high, very small, is another one. Those we know. I mean, we are trending in really positive land. I mean, MSI high, it's a slam dunk. But for the BRCA, again, with the right agents, we will be able to move the needle significantly in those. And the others, we'll have to see. There are a couple of interesting and promising agents that are making their way. I'm not going to be bets there. I'll just wait.
Ramesh?
Well, I think somebody will find the key to immunotherapy use in pancreatic cancer in a subset more, not MSI, but maybe 30, 40, 50% co-stimulatory molecule, vaccines. I think that'll be a big breakthrough with immunotherapy in pancreatic cancer. It has to happen. If it can happen in melanoma, why not in pancreatic cancer?
Winson?
Yeah, I think we're learning that, in pancreatic cancer, it's a very heterogeneous disease, and I think the money is really about enriching the right patient subsets and targeting therapies to these individual groups, and not treating all comers as one disease. I think that's where the focus should be.
Manuel, your bet.
Well, everything has been said, but I think that if we had a good RAS inhibitor,
Yes.
perhaps we could do some improvement.
Yeah, lots of development going on there. Very
yeah, a
exciting.
lot,
Very exciting. And my personal for new approaches, I think it's going to be a combination of immunotherapy with a microenvironment drug. But we'll see. Guys, this has been so informative. I'm so thankful to have you all on the panel here with me. I'm going to go through everybody again and just get some final closing thoughts on what you think people should take away from this panel. And I'm going to go backwards now. Sorry, Thomas. Manuel, what would you be, what people should take away from this?
So I think that my summary message is not to give up on the patients too soon. I think to have multidisciplinary care is critical to identify the patients that can be treated with either adjuvant or neoadjuvant curative approaches is critical. So multidisciplinary care, and then really enrolling patients into clinical trials with good and new combinations is what eventually will make a difference in this disease. But we have made some progress, and I think that there is the opportunity that we will make more progress if we continue working together and incorporating new strategies.
Winson.
Well, I think it's exciting times because there's many things going on. But earlier, I think a few of us had also mentioned that in the current trials, the vast majority are young patients, ECOG 0 and 1. And as a health outcomes researcher, I kind of think about the routine patients that we see in clinic. So it'd be nice to see more pragmatic trials where ECOG 2 individuals and older people were enrolled as well. And along the same lines, maybe doing some outcomes or population-based studies to look at, how our agents are proven to work in clinical trials. How are they actually being used in real life?
Very good. Ramesh?
Well, just to pick one aspect, I think pancreatic surgery should be done in a specialized center. I think the guidelines are at least 18 to 20 pancreatic cancer surgeries per year. That's not a very high bar, but amazingly, there are not many centers in the US which do that kind of volume. So it's, at least for surgery, I would say please refer to a center with experience.
Very good, very good. Tony?
Closing thoughts, I think this is a much better time to be taking care of patients with pancreas cancer. I think we can provide our patients with more hope now than ever, and more hope for the future.
I love it. Thomas?
I agree with all what's been said so far. I think to me it's important because with the era of genomics, we have to put patients whenever and wherever into trials, but we also have to take an effort to collect biomaterials because we rely on those to really take decisions in future on the treatment. And when we don't have a trial has enough biomaterials, tissue, urine, blood, whatever, we need to collect that, we need to have that. This is an extra effort, but it's worthwhile because then we can take the consequences.
I love it. An overall message of promise and hope. Thank you guys, all of you, for contributing to the discussion. I think this was a great panel. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.